footprint, we have kind of lots of other things. We describe ourselves as a human data science company. Human data science underpins absolutely everything we do, whether it's our clinical trials, our real-world evidence studies, or the work that we deliver directly for the NHS. So we have a footprint in pretty well every hospital in the country, where we're supporting directors of finance and teams with patient-level costings, with benchmarking. And we're also doing a huge amount of work on care pathway redesign. So I just thought you might think, who the hell are IQVIA? And some people say IQVIA. So who are IQVIA? I just wanted to do a little bit of a kind of footprint. We are the world's largest commercial clinical trials organisation. And in the UK, we bring more globally sponsored by big pharma and biotech studies to the UK than any other organisation. We have a footprint right across the UK, and the way in which we tend to run our clinical trials is we work with a model that we call prime sites. So we have 3 prime sites in the UK, which is a great complement to the clinical research ecosystem that is the UK, because for a population of 65 million, we wouldn't normally have 3 prime sites. So we have a prime site, obviously I'm clicking away here, prime site in the peninsula, so all the hospitals south of Bristol. So we believe that that plays a very important role in bringing access to clinical trials for people living in coastal and rural communities there. We have a prime site in London with UCL Partners. And then our most recent prime site, which we did as part of the Life Sciences sector deal back in 2019, is the Northern Prime site. So many of you clinicians in the room will be part of that. So that is all of the hospitals out of Manchester, across the M62, to the other side of Bradford. And we appoint these prime sites because, you know, they have the best clinical leaders in the country. And in particular, they demonstrate that they are health data enabled. Because when you are looking to get global studies and bring them to a country like the UK, it's really important that you get the first patient in, and the first patient in quickly, in the best centres possible. So that's a little bit about our footprint. We have kind of lots of other things. We describe ourselves as a human data science company. Human data science underpins absolutely everything we do, whether it's our clinical trials, our real-world evidence studies, or the work that we deliver directly for the NHS. So we have a footprint in pretty well every hospital in the country, where we're supporting directors of finance and teams with patient-level costings, with benchmarking. And we're also doing a huge amount of work on care pathway redesign. We're also doing a lot of work intervening upstream, and I know Adam's got a fantastic quote from Desmond Tutu coming soon, but it's about supporting the NHS with recovery. So we have teams of clinical pharmacists and nurses who are working in primary care networks and GP practices, implementing programs for COPD and heart failure, using the health data, using the electronic medical records, and then conducting face-to-face assessments with them about, are they getting the optimal care for their COPD, their heart failure. We've built in algorithms, so we've built AI algorithms to support the GPs so that we can leave things behind, so that they can carry on using those algorithms going forward. And we're building a healthcare analytics network in which we expect to have 15 million primary care patients in it by 2025. We also have a 50-year relationship with the NHS hospitals in this country, whereby the pharmacy department send us their prescription data every month, and it goes into what I call our sausage machine, and it comes in like a big lump of sausage, and then we analyse that and feed that back as dashboards to the hospitals. So, for example, how are they performing in terms of antibiotic usage or other dashboards that NHS England are measuring prescriptions on. We also sell that back to the pharmaceutical industry so they can see where their products are being used, how they're being used, and if they're being used in line with NICE guidance. It gives us insights to things like how long does it take for a NICE technology appraisal to be taken up at local level? And I can tell you the answer to that is 4 years and 2 months. And that's not even to the standard of the lowest estimate that NICE and the pharmaceutical company agreed should be the uptake. But, those are the kind of insights that we can then feed back into the centre. We also help the centre with these insights when there's medicine shortages. And we have that kind of service all over the world. So we're able to look at supply chain all around the world. So you can imagine during COVID, when we started to see medicine shortages, that really came into its own. And being able to feed that into governments was really important. We were asked a little bit late on HRT. I jumped in on the strep A and the penicillin thing because our data was showing us that whatever Steve Barclay's people were telling him in the department, we were going to be out of penicillin like within a matter of 10 days in this country. If it carried on the way we were going. So that's the way we use data for good. So I didn't mean that to be too much of a commercial, but I hope it gives you a little bit more insight into who we are and why we're doing an event like this, because we want to be connected. We want to be intimate with your problems at ICS, with the challenges that you've got. And we want to see if we can bring solutions and partner with you on those. So just moving through, we also did, I got a call just literally 24th of March, day after Cheltenham, which went ahead, as you know, in March 2020, to say, can you help us? We don't know what the circulating level of COVID is in the UK community, and Public Health England could not come up with the answer. Can you mobilise people? Are you going to furlough staff from the clinical trials? Can you get people out doing bloods and swabs in a pilot in London, 10,000 people? And also, can you build the data platform for it? And how quickly can you build it? So we kind of said yes and yes. And then Boris came out of ITU and it suddenly went from a pilot of 10,000 to become the National COVID Infection Survey. So by the end of that, we were employing 4,000 people doing those bloods and swabs 364 days a year. And that informed the R rate. So if you want to blame anyone, sorry, we were the backroom people informing that. But you can imagine we were super proud of our role in that. And as a business, it showed us a capability we didn't even actually know we had to do large population health surveillance programs. So we've now built on that capability, and we're working with CEPI, we're working with Gavi, and what we're doing with that is how can we bring, at speed, new medicines and treatments for pandemics to low middle income countries. So that's something that we will continue to do. Just moving on, just a little bit of context. So, the political uncertainty as we're running up to the general election, this government, you have to say, has had policy vomit. I study policy. That's, kind of thing that keeps me awake at night and sends me to sleep at night. I have never seen so many policies come out for life sciences over the last 5 years. But, you're on the receiving end of them. You're having to implement them. So, of course, we had the cancer plan sort of subsumed into the major condition strategy in January, which Steve Barclay announced, and the detail is still to follow. And my kind of question to the audience is, with everything else that you've got being forced down on you, where do these policies fit in your operational days? And actually, do they make a damn bit of difference? And in fairness to Barclay, he did say, look, policy isn't going to sort it, but we do actually have to stop looking at people in a silo condition of, oh, it's cancer. And remember that they've got COPD, they've got heart failure, and we need to try to be treating them holistically. The COVID-19 disruption, the backlog is, I don't need to say anything to you about the waiting lists. I'm 40 years at this and I've never seen such waiting list times. And I did run a small hospital in the northwest of England back in the 90s, and we were doing waiting list initiatives, sort of 24/7. And then it wasn't so bad. So goodness knows how it is now. The workforce, very good report. I don't know if you saw it from the RCGP, Fit for the Future, just 2 weeks ago, just basically calling out that 25% of practices are saying that they fear that they will be closed within the next 18 months if they cannot get more GPs into the system, and if the demand continues the way it is. And of course, you'll all be aware now of the shenanigans, as always, around the GP contract and the kind of tensions that is really exacerbating. The attractiveness of the UK for research for new medicines. So the UK used to be the country in which global pharma prioritised to launch its new medicines. So it would be the third country in the world after the US and Germany where we would prioritise medicines launch, despite the fact and the historic record of low and slow uptake. And I already alluded to the 4.2 years to get a nice technology implemented. The industry and the government have a payment scheme which is negotiated every 4.5 years, called the Voluntary Pricing and Access Scheme. And I'm afraid this year it really created a challenge because there was a clawback of just over 27%. We've never had double figures, certainly never had anything like that. And a number of companies have actually said that they're going to pull out the scheme. And if you can't launch a medicine in the UK, you are not going to do clinical trials in the UK. So it ain't great. And any of you who read the press will have seen of that. And then, of course, you've got the devolution of specialised commissioning. And then you've got a 40% cut in the NHS England headcount. And it's all coming down to you. Looking at the maturity of the ICSs and talking to people like yourselves, it's like, really? Honestly? So again, I think that that's an area that life sciences would really like to collaborate with you, because obviously for their particular therapeutic areas, they have a huge amount of expertise. So I'm going to just kind of finish there. The elective activity, I'm afraid this was from the HSJ. Greater Manchester Health and Social Care were right at the far end of the recording more inpatient elective activity in the 3 months to December than the same period before the pandemic. So, you know, pretty challenging stuff, but I'm not going to teach Granny to suck eggs. My optimism is population health and health inequalities. And we're going to be doing a huge amount of conversation about health inequalities today. Working with our life sciences customers at the back end of last year, I was talking to them and saying, what priorities are you going to be engaging with ICSs around? And to a man and a woman, it was health inequalities to improve population health. So many of them have already been working in this space. Many of them have some fantastic initiatives, and we'll hear about some of those today. They can be your partners, and they will invest in those when perhaps you don't have money to invest in them. So, you know, let's move forward this afternoon in that great spirit of collaboration.